Hi, good morning to everyone who's joining us in the webinar. We're just setting up the technical aspect first. Okay, I think everything's in order. Thank you, Elena. All right. Yeah. All right. Good morning. Good morning, everyone. Thank you for coming today and joining us on the webinar. We have a pretty packed agenda, so we're going to get right to it. This is the Attachment 7 Refresh Workgroup discussion on health equity. We're going to start off with introductions of the folks in the room. And start off, I'm Ty Lee, the Senior Quality Specialist here at Cover California.
Carrie Sanders, Senior Director of Policy at the California Pan-Ethnic Health Network.
Health Equity Officer, Cover California.
Todd May, Senior Medical Director, HealthNet.
Nancy Wong, Collab Director of Health Education, Cultural and Linguistic Services with HealthNet.
Health Access.
Michael Nguyen, Director of Policy for Molina.
John Williamson, an attorney with the Department of Mental Health Care.
Christina Wu, California Association of Health Plans.
Katrina Reyes, Associate Director, Center for Health Policy, California Association.
Jan Fontarana, Deputy Director, Plan Management Division.
Carlos Flores, Business Development for Valley Health Plan.
Carolyn Craig, Care Interventions Manager, Oscar.
Marcy Reader, Blue Shield of California.
Rob Spector, Blue Shield of California.
Amber Kemp, California Hospital Association.
I'm James Benedetti, Director of Plan Management.
Alina Wise, Plan Management.
Folks in the back.
Margaret Brandt, Plan Management.
Ty Panacorvo, IT, Cover California.
Corey Barajas, External Affairs.
Lisa Gonzalez, External Affairs.
Betsy Aguilio, Plan Management.
Hugh James, Plan Management.
Jacqueline Pay, Plan Management.
Gina Ivanko, Plan Management. Rivera Silva, Manager, Cultural Linguistics, HealthNet.
Amy Frist, HealthNet. Michelle Huda, Western Advantage.
All right, thank you. And for those folks of you who are joining us by webinar, we do want to acknowledge you as well. So if you would like to introduce yourself, please raise your hand and we'll allow you to introduce yourself.
Christoph, you've been unmuted. Hi, Christoph Stremicus, California Healthcare Foundation. Mary, you've been unmuted.
Mary Jamona, Medical Director for Molina Healthcare.
Mary, you've been unmuted. Rick, you've been unmuted.
Rick Crum, Anthem Blue Cross, our exchange director. We also have other representatives on the line as well.
Lindsay, you've been unmuted.
This is Lindsay Goldhorn with City of Hope.
Robin, you've been unmuted.
Robin Gaines, California Healthcare Foundation.
Jen, you've been unmuted.
This is Jen Flory with Western Center on Law and Poverty.
Okay, some of you in the webinar raised your hand, but we can't unmute you. I think you may not have added your participant ID. If that's the case, and so that means that your mic is not working on our end. If that's the case, you may want to log off and then log back in and enter your participant ID. That was sent to you in the email after you registered. Okay, is there anybody else?
Annette? Ellen, you've been unmuted.
Hi, this is Ellen Rudy from Molina Healthcare, oversee quality.
Don, you've been unmuted.
Don Hufford, Chief Medical Officer, Western Health Advantage.
Emma, you've been unmuted.
Emma Hu, Pacific Business Group on Health.
All right, thank you. And sorry, we couldn't get to everybody online. All right, next is this is our agenda for today. We're going to start off with Carrie Sanders doing a presentation, and then we'll do a roundtable discussion on the 3 buckets there, and then we'll wrap up and go on to next steps. Right, I'm going to hand it over to Carrie Sanders. She is the Senior Policy Director at the California Pan-Ethnic Health Network, or CPEN.
Okay. Can everyone hear me okay? My name is Carrie Sanders. I'm the Senior Policy Director with the California Pan-Ethnic Health Network, appreciate the opportunity to talk with you all today about advancing health equity as part of health system transformation efforts. I wanted to start with a little bit of background about our organization. CPEN is a statewide multicultural health advocacy organization. We were founded in 1992. Our focus is on eliminating health disparities, and in particular, through expanding access to care, improving cultural and linguistic access, also looking at social determinants of health, so really thinking about upstream approaches to health and how oftentimes where we live, work, and play impacts our ability and our health outcomes. And then finally, in order to eliminate disparities, we do a lot of work on properly collecting and reporting on data related to demographic data so that we can actually measure and identify disparities and address those. We have been working, very key to our mission as an organization has really been looking at this issue of health system transformation. Starting in 2001 and even earlier, we actually worked at the California Healthcare Foundation on a brief way back when on the use of standardized patient satisfaction surveys in assessing the cultural competence of healthcare organizations. So, back in the day when we were just, beginning to talk about CAHPS and we were beginning to think about how to measure performance and to improve access to care, CPEN was at a lot of those tables talking about the importance of ensuring cultural and linguistic access and really measuring health outcomes for the diverse populations in the state. And just, again, just a little bit about our work, both, in terms of policy. We also connect and convene networks throughout the state. So we have partners, community-based organizations who work directly with racially and ethnically diverse consumers throughout the state. We bring them together to talk about and help inform our policy strategy. We also work with them to amplify some of their concerns and voices and bring them to the Capitol, to Sacramento, to engage with policymakers on these issues, including health system transformation and health equity in general. So today, I just want to talk a little bit about, why now? Why are we talking about health system transformation and from an equity framework. And then I'm going to talk a little bit about what our vision is and how we can get there. So, just to review, and we all have hopefully seen this, but under the ACA, California has really moved forward in reducing disparities in health insurance coverage. Prior to the ACA, 60% of folks of communities of color were uninsured, but now, thanks to the Affordable Care Act, those disparities have really decreased to the point where there's the remaining disparities really with the Latino community due to other factors, including eligibility for coverage. But when you look at the numbers, it's things have really improved. We've done a great job as a state of reducing disparities in access to health insurance coverage. And so now it's time to look at outcomes. When we look at health outcomes and we look at the history, we know, for example, that Latinos and African Americans still have twice the prevalence of diabetes and are twice as likely to die from the disease. So even holding health insurance coverage constant, this continues to be a problem. American Indians and Alaska Natives are 3 times as likely to have asthma than the state average. African Americans have exceptionally higher rates of asthma prevalence, 40%, which is, and also 4 times higher asthma ED visit and hospitalization rates, and 2 times higher asthma death rates. And this is just, for asthma and diabetes, but we also know that there are disparities in terms of mental health, in terms of hypertension, in terms of a lot of common chronic diseases that impact Californians, but impact communities of color disproportionately. With the Affordable Care Act, there was a focus on the triple aim. The thought being that now, once we have people in health insurance coverage, we can now really improve the healthcare systems that offer care through this 3-pronged approach of lowering costs, improving quality, and improving population health. And while this, I think, has been a really important framework and, the 3-legged stool that so many of us are now familiar with, oftentimes when we talk about the triple aim, there's really no focus on health disparities and eliminating health disparities. And the problem is, health disparities are persistent. They have been they continue to persist despite changes in demographics, despite changes in insurance coverage and insurance penetration rates.
Carrie, can I ask a question on this slide, or do you want to wait till your presentation's over?
Maybe just...
I can wait.
Okay. Why disparities? The important point that I think we want to highlight is when you ignore disparities, you risk leaving them in place or worsening them. So often, again, with the AAA, when we think about improving quality, the first step is that providers or plans may take is let's try to go with the low-hanging fruit. We're going to improve immunizations or improve look at process measures where we can show improvement right away. But if you're not really addressing or thinking about where those gaps and disparities are, you may overlook them and in fact potentially worsen them. And I wanted to share this example in Medi-Cal. In the Medi-Cal program, the state health systems learning group looked at maternal mortality rates. And there was a decade-long study of maternal mortality rates in California that looked at before interventions and after interventions. And one of the main findings was that despite all the efforts that California took to improve maternal mortality outcomes, which actually, we have been recognized nationally for those efforts, that in fact there was these persistent disparities even through this intervention, to where African American mothers are still 3 times more likely to die while pregnant or postpartum than other mothers. And this is the disparity ratio, which has held fairly constant. So, the theory is really, and I think that one that's been proven successful is to really look at individualized, equitable care. And this is, again, I think where Cover California is going, and where we, really feel this is the right direction. When you think about, trying to eliminate disparities, it's oftentimes, there's often questions about, different ways to go with quality. In the past, the traditional way is to look at, well, let's improve care for the average population, the average person. And if we improve care for that person, maybe we'll bring other groups along. But in fact, I think Kaiser and other health systems that have been looking at this issue have actually found that when you try to improve care and reduce disparities at the same time, that oftentimes the interventions are put in place to address concerns of your most vulnerable populations will end up improving care for all of your enrollees. And so I'm just going to have this example here. Kaiser had an initiative, the Equitable Care Health Outcomes Initiative, which was to eliminate disparities. And in particular, they looked at controlling for high blood pressure. One of the things that they found is that health literacy and language proficiency are predictors of disease control. And so they looked at an intervention that really focused on improving communication strategies, both for medication adherence and for ensuring understanding of treatment plans. And, as I mentioned earlier, they found that improvements, that not only were they able to close the disparities gap for this particular metric, but they improved care for the entire population by really analyzing and thinking about the way that they were communicating to their patients. So Cover California, in 2017 took a very historic first step in reducing disparities as part of its Attachment 7 requirements. I'm sure most of us are familiar with these, but there were it was a two-pronged approach. First was really requiring health plans to improve data collection efforts to move towards collecting 80% self-reported identity data from patients. Self-reported data is the industry, it's kind of the best practice for how to collect this data, because essentially it's self-reported. It's coming from the patient as opposed to looking at surnames or geocoding or making assumptions. I think so that was a very important initiative. The second initiative was really going back to these chronic conditions where we know that there are disparities that exist, and in fact, there are interventions that can help to prevent them, which is another important distinction. The exchange looked at diabetes, hypertension, asthma, and behavioral health, and said we're going to work with health plans, work with folks here to think about how we can set year-over-year targets for the reduction of disparities in these areas. But before they did that, they began by collecting baseline data. Health plans provided data for several years so that they could understand, where plans were starting from, and then build from that to better health outcomes. Finally, a third component of that, and in the contract in Attachment 7, is the ability to expand or potential to expand to other subpopulations, some of these Attachment 7 requirements, including to limited English proficient, LGBTQ+, and other subpopulations where we know that disparities exist. And in fact, oftentimes we find that the disparities are intersectional. So, they're exacerbated for folks who have multiple identities. We, in our own research, have, in looking at mental health disparities and looking at disparities more broadly, but also in this particular area, we've found that a multi-pronged approach is really important. You see this also with a lot of the national research. Dr. Chin's research, Finding Answers through Robert Wood Johnson, really looked at how, while data collection and reporting and, the attachment 7 requirements that we just looked at are definitely extremely important, you really need a multi-pronged approach of various interventions throughout the system if you're going to actually improve health outcomes, if you're going to move the needle on eliminating disparities. And so some of the findings from our strategic plan to reduce mental health disparities in California really kind of found that with this multi-pronged approach, it's not just, you want to improve data collection standards, but also that it's important to address the social environmental determinants that impact health or that keep people from obtaining coverage. You also want to implement capacity building at all levels. So looking at health systems and really thinking about how you're building the capacity of those systems to address the diverse needs of consumers. And again, thinking about how you build your care teams to address the needs of population. So again, we come back to this term, equitable care. We are huge supporters of the concept. We appreciate Cover California for embracing this framework of care where equity is really a central focus of quality improvement efforts. For all the reasons stated, I think when you don't have equity at the center, the risks outweigh the benefits, or to flip it, the benefits outweigh the risks. In terms of this framework, I think we're excited to have these conversations with equity, a central component as we look at not only, attachment 7 data requirements, but when we talk about primary care and some of the other directions that Cover California is looking at with QHPs, with qualified health plans moving forward. So I wanted to just take a brief, provide a little bit of kind of a brief kind of detour. When we talk about centering health equity, we at CPAN have actually been, we received some funding this year with the California Healthcare Foundation, where we've been looking at and assessing health system transformation efforts in the state, and trying to identify equity opportunities, but also just where equity is being advanced and where it's not. As part of that, we have a consumer engagement component where we've been gathering input from community members and consumers through focus groups and through regional convenings, where we're really trying to understand, what consumers are saying and about their experience with healthcare. And with that, we hope to develop recommendations to eventually create a roadmap that we can put forward to help advance policies, not just in Cover California, but statewide across systems of care, from physical to oral to mental health. But one of the key aspects of this has been the consumer engagement aspect, and I wanted to share some of our findings with you all today, because I do think that as we talk about these interventions from a clinical, I anticipate that we'll have a very clinical conversation about, care teams and patient-centered medical homes and all these, all this terminology. It's important to, I think, to ground ourselves in what are communities actually saying and how are they experiencing care. CPAN partnered with six organizations, 6 of our partners throughout the state, to conduct regional focus groups in racially, ethnically diverse populations. So we worked with Latinx, Asian American, American Indian, Black African American, and then we also have a focus group on individuals with disabilities and LGBTQ plus individuals. And the goal was really to engage diverse stakeholders, including communities of color, persons with disabilities, LGBTQ plus, in meaningful discussions regarding their experiences accessing care in order to ensure more equitable health outcomes. Our criteria for doing this was that the consumers had to have used services in the past year. We didn't just want a person who, was newly insured but never goes to the doctor. We wanted to be able to hear from consumers, who had insurance or in some cases didn't, and used their county safety net. What was their experience when they went to the doctor, when they went to the ER, when they went to try to find a specialist? We spoke with folks from a variety of ages and family configurations, with a variety of lived experiences, including languages spoken, countries of origin, immigration status, et cetera. And close to 50 people we have surveyed so far. 2 focus groups were translated. One was in Spanish, and the other one was American Sign Language, and we had interpretation for that. And this is sort of a sampling of some of the different groups that we spoke with. And one of the things that I think was really interesting about this is that even within the focus groups, there was quite a bit of diversity of experience and racial ethnic background. So I just want to start by saying there were some very positive experiences that folks had with their health care. I think, an example is a person in our LGBTQ focus group who was assigned a primary care doctor, showed up at that doctor's office, and that doctor said, by the way, provider, so-and-so works, very closely with gay men, and if you would prefer, I can refer you to this other provider. They then went to that provider and experienced really great care. So I think, I want to note that there were some really positive experiences that I think are very instructive. We also, we also kind of wanted to pull out some of the experiences that were not so positive, but mainly in terms, in order to talk about what we could, potential interventions or ideas that we could, promote together. So some of the themes that came out were barriers to accessing care. Those continue even with health insurance coverage. Difficulty navigating the coverage system, stigmatizing or disrespectful treatment, poor patient engagement. But then the flip side of that is a general desire to engage in feedback mechanisms with proper support. So even though most of our participants had some form of healthcare coverage, many still reported challenges accessing care. Excuse me, and these included long wait times, both for appointments and at facilities, high out-of-pocket costs, especially for dental services, lack of access to specialty care and mental behavioral health, so that continued to be a challenge, transportation barriers, especially in rural areas, no affirmation of language rights, and what I mean by that is we asked participants if they were informed that they had, a right to interpreter services, and most of them said they were not aware of that. And then in the cases where folks did get interpreter services, the quality was really uneven. So some people said, it was fine. Other people, though, talked about, poor quality or just, a real kind of concern about the level of interpretation. The other issue that was highlighted, difficulty navigating the coverage system. Participants at every focus group talked about how complicated the current healthcare system is and how difficult navigating, particularly insurance systems, sometimes impeded their ability to get care. Some of the complaints included, difficulty understanding or getting up-to-date information in provider directories, difficulty with health plan support lines, not being very helpful, people, calling and not getting the assistance they needed, difficulty reading or understanding documents such as handbooks and billing. And then another issue too is just shifting eligibility often can lead to unpredictable lapses in coverage. So as people move between, Covered California and Medi-Cal, or employer-based insurance and Covered California, that there's some confusion, a lot of confusion for consumers. The other area we looked at, and again, just, given our participants and the diversity of the participants, was their experiences in feeling, respected and their concerns addressed. Participants shared many stories of feeling mistreated by providers, often in ways that made them feel reluctant to seek further care. So, and this was across the board for, for language, race, sexual orientation, gender identity, disability status, or size and weight, including unwelcome comments, unwarranted assumptions about a person's lifestyle, or ignoring a patient's holistic needs based on a single aspect of care. And, a couple examples. One, African-American participant who showed up at ER with stomach and felt that the doctor assumed that he was on opioids and refused to treat the underlying problem. Another example is for a person with disability who needed, wanted to talk about reproductive care, and a provider sort of saying, "Oh, I didn't know you were active," or what, really? Do you want to discuss this? Really making that person feel stigmatized, that all they're being seen for is their disability. And so those are just some examples of what we saw. The other area was really around poor patient engagement, and I think part of this is systemic. It's not just that it's on the physician, but the times feel excessively short to folks, and this is a particular concern in rural communities where it can take 2 hours plus to drive to a doctor's appointment, where going to the doctor is not just a 15-minute run to the doctor and back, but taking an entire day off from work, and then only having a 5-minute appointment. People felt like there was, and in fact, that is one of the examples that came up was a person who lived, I think, in Santa Barbara and had to drive to Oxnard to get their care, and reported, spending 5 minutes with their doctor and feeling like, I may as well just Google my symptoms or go to urgent care. Inadequate or lack of explanation about medication, medical procedures, or home care instructions. Patients often feel rushed to make decisions or bombarded with paperwork. So we ask folks, when you're, told you have, you need surgery or something is going to happen to you, how well does your provider explain to you what's about to happen? And several folks talked about, I didn't understand what was happening. They came in and had me sign this paperwork, and then, the next thing I knew, I was being rushed to the surgery, and I didn't understand why or what was happening. and then also physicians themselves not having language capacity. So another example, a woman rushed her mom to the ER because she was having difficulty breathing. She was prescribed an asthma inhaler, but nobody explained to her how to use it. It took 3 days for them to get in to see the provider after the visit to understand what the prognosis was. And when they finally did get to see the provider, they didn't speak their language. So there were a number of different issues happening. The last piece, though, there is hope in the sense of, for all of this. I mean, for negative stories, there were positive experiences, as I mentioned, and also a desire to engage in feedback. But we found with our participants that most people didn't know that they could provide feedback or how. People are more often inclined to provide positive feedback. Negative feedback is there's concern about, can I share this with my doctor? Will there, is this going to impact me somehow? And as one participant said, when you go to a restaurant and something's bad, okay, give me the manager. I want to talk to them about this. But if you're in a hospital, who do you ask for? Is there a president? Is there a customer service department? There's just a kind of lack, there's a disconnect there for, folks experiencing care about how to engage in the system. Other of our focus group participants talked about how, if they could get, if there were proper support for them to engage in feedback mechanisms, they would happily participate. If there was daycare or babysitting, if it was after hours, for example, at a convenient time and place that they can get to, if there was language accessibility, they would be willing to provide and feedback on their experiences. A couple of different additional themes just to highlight. The intersectional experiences, I talked about this earlier, but one can experience multiple forms of discrimination or inappropriate treatment due to multiple identities. So I talked about the example of the African-American male who was hard of hearing, who felt like, all of these things were happening to him. And so just important to think about, how those identities can make and exacerbate those interactions, and the importance of, cultural humility and training. Use of technology, patients really appreciate text and email and patient portals. They can be very helpful. They're not a substitute for in-person conversations, but people do find them helpful, and they are taking advantage of them, I think, more and more. And then there was also a theme about alternative care across racial and ethnic groups. Many reported using traditional non-Western treatments, and the desire to be able to talk to their doctors about this, not so much to supplant what doctors are prescribing, but to supplement. And in certain situations, feeling like, they wanted to have those conversations, but didn't feel like they could with providers. So for us, as we've been looking at the findings and thinking about, what does this all mean, we kind of see 6 sort of key strategies. We talked about the multi-pronged approach to improving or achieving health equity. With the first really looking at, improving self-reported collection and reporting of quality data, strengthening access to culturally and linguistically competent care, investing in primary care, strengthening care coordination, improving patient engagement, and addressing the social determinants of health. What do we mean by some of these, by these particular strategies? We have some specific, recommendations. I think also these are things that I just want to stress that I think these are things that Cover California is talking about. Maybe some of you are already talking about. I don't think these are necessarily new, but starting looking at race, ethnicity, and the data collection piece, I think, obviously continuing to strengthen and the reporting and accountability in current Attachment 7, as part of current Attachment 7 requirements. We also think, given this data, that it's important to expand Attachment 7 to other subpopulations, including limited English proficient, LGBTQ+, persons with disabilities. As we saw from our focus group findings, again, they have very unique health needs and are particularly vulnerable, and we need to figure out how to address those. Collecting better patient data on interpreter need, access, and quality. This, again, arose, I think, from the lack of information and that consumers need to have about their rights to ask for interpreter services, and the quality, the kind of range of quality that folks experienced. Monitor and reporting on the provision of language services. We think this is also really important in order for understanding of how the services are being accessed and used by consumers. The next strategy 2, strengthening access to holistically competent care. We really feel like when we talk about access to interpretation, that it's definitely we need to think about it in terms of medical care, but also from a care coordination, case management, and patient navigation experience. Oftentimes, when the patient walks through the door, it's the person at the front desk that they speak with, or the PA, or the community health worker who's kind of welcoming them and getting them in the door. We believe that this is really an important part of improving care for communities of color, is really thinking about, and for vulnerable communities, is how to scale up the use of bilingual, bicultural community health workers, community-based navigators on care teams. Also, and we'll talk about this more later, but I think California is also thinking about incentivizing or encouraging the adoption of patient-centered medical homes, just because, that is kind of more of a care team approach. And then making implicit bias training and trauma-informed screening and referrals, which have been shown to improve the quality of care, more of a required activities for providers who contract with QHPs. And we think that this is so important, particularly, again, as we, talked with folks. It's, implicit bias is, something that everyone can benefit from, the training, and it goes across, racial ethnic groups. It goes across, ability level, disabilities, LGBTQ, other populations as well. Investing in primary care, again, talked a lot about the adoption of patient-centered medical homes. I think there's, we know that Cover California is interested about this with providers and plans. We think it's really important. We've seen in other states, looking at Oregon, for example, they adopted their own version of a patient-centered medical home, and 90% now of Medicaid recipients are now assigned to a patient-centered medical home, and that's within, I think, a 2 or 3 year period. So they've had quite a bit of success with that. However Cover California decides to do that, it seems to be an important component and a way to improve access at the primary care level. There are also, we note, alternative payment models that Cover California and QHPs may want to explore, that to encourage and to look at more enhanced primary care. So improving care coordination, the next strategy. Again, we really saw and noticed that there was a disconnect for many consumers about getting care across systems from, your physical, dental, and mental health, that a lot of times the systems don't talk to each other, and there was really confusion about where to go. So, part of this, I think, is really, oftentimes your PCP is, the primary person, the primary contact that a patient has. In some cases, PCP is the first person who hears about anxiety, depression, and other symptoms that that folks are facing. And so really thinking about, how can we ensure that, providers are and plans are helping patients make those connections to these other forms of care. And again, I talked about this earlier, but in this conversation about care coordination, community health workers and care teams can play a really important role in helping to make some of those connections and to make those referrals and linkages between systems of care. And then almost there, this is number 5, improving patient engagement, requiring QHPs in the Medi-Cal program. Health plans are required to have community advisory councils that are representative of the populations that are served, that help to advise them about their systems of care. Cover California has attachment 7. Oregon has this new attachment K, which I don't know if folks have taken a look at, but there's some very interesting ideas in attachment K about how, some potential strategies for improving consumer engagement and making some linkages between consumer engagement and quality strategies and quality improvement. As part of that, thinking about, using consumer advisory councils, which include or should rightfully include providers as well, to draft and think about community health needs assessments and come up with plans, regional plans for how to address disparities, as well as interventions to strengthen quality and performance outcomes. And then finally, there's a lot of conversation about addressing the social determinants of health. I know Cover California is going to talk about that today. But I think there's some basic steps that plans and providers can take, starting with screening patients for social needs and actually making referrals, including to housing supportive services, food and nutrition centers, and looking at things like rental security and medical respite and recuperative care as, areas for referral as well. Again, as I mentioned earlier, thinking about having health plans conducting local and regional community health assessments and improvement plans. And these are not just looking at the membership of the plan, but kind of challenging plans to think more broadly about what are the local and regional needs, because those unique needs are going to really feed the interventions. If you're in the Central Valley, for example, the air quality may be an issue that impacts all of your members across the board. And so really partnering with public health departments, with other local groups to think about what those community needs are. Bringing CBOs into contractual relationships to identify opportunities to integrate social determinants of health. We see this, happening in Medi-Cal with some of the pilot programs, the whole person care, the health homes program, and we know that those programs will hopefully be continuing, and then finally submitting data on the social determinants of health and beginning to make some significant investments in those areas. Again, I talk about, I note Oregon's attachment K, but also some of the research of the California Healthcare Foundation in looking at how plans can potentially keep some of their savings when they invest in quality improvement and use those to reinvest in social determinants of health in some of the things that potentially can improve care from an upstream approach. So lastly, I just want to mention a couple of additional resources that exist at the national and state levels as we have this conversation and think about what next steps look like. Excuse me. And I talked a little bit about the integrated and delivery system reforms to solve disparities. The Finding Answers results. These were interventions that happen at the looking at various states using multicultural care teams and really trying to understand how and to what degree they positively impact health outcomes. There's some really great data that can be gleaned from that. The National Quality Forum's Roadmap for Promoting Health Equity and Reducing Disparities. This came out in 2017 and provides a helpful roadmap to health plans, providers, hospital systems, organizations for steps that you can take to improve health equity and as part of your infrastructure and your systems. I also just want to note, while this may seem new for some health plans, there's a National Health Plan Collaborative that has been working on reducing disparities since 2008 and they've actually developed a toolkit that can be used by plans and systems that are thinking about taking on this big task of ensuring more equitable care. And then lastly, again, just flagging this new attachment with the through the Oregon Health Authority model contract that's trying to link this both consumer engagement with social determinants of health and really trying a new approach to how health plans and providers can work together to improve care and reduce disparities. So with that, I'll stop and.
I would take questions. Those of you on the webinar, if you have a question, you can raise your hand or text it into the comment box.
Curious, the attachment K in Oregon for Medicaid plans in that state? I'm not familiar with the authority.
Yeah, so the Oregon Health Authority is it's primarily for Medicaid plans, correct?
You mentioned the folks in your focus groups, some of them were not insured. Roughly how many were insured?
I would say about 3/4 had some form of insurance, and about 1/4 did not.
Michael, follow-up question on the participants for the focus. Primarily Medicaid or Medi-Cal, sorry, or if it covered California or a combination?
Yeah, it was a combination. There were folks that had commercial insurance. There were folks who were on Medicaid. And I'll just say, as phase 2 of this, we've actually been taking some of these findings out to kind of a broader subsection and doing regional convenings where we're sort of checking out, is this what you're finding with an even kind of larger group of folks? But it was definitely it's been across different systems of care that people have been sharing experiences.
So on your map earlier, displayed some of the states that were, performing in the top quartile. Are there any specific factors that lead to why those states were performing better in the health reductions and health disparities reduction? Was it better data? Was there demographics of their provider network matching their population? Was some of the factors, can you share some of those information?
I don't have as much, I don't have like specific data on other states or kind of to be able to talk about that, but I think One of the things that I would just highlight is, California has, as our diversity has expanded, the issue, and it's sort of happened with other states too, the issue of health equity and health disparities, I think becomes more urgent because you have a bigger population and a more diverse population that has different needs. And so that's one component. I think the other component is just that disparities are very persistent because it's not just it's not just clinical outcomes that are causing it, but actually, other factors, some of the upstream factors that I think kind of necessitate this conversation around the social determinants of health. And so I think it's a combination of different factors.
It's like us here.
Yeah. Yeah.
Any questions? I'm listening.
Quick question, or another question. Your slide around self-reported data, and you had noted that was best practice, and I'm going to use the new guy card because I don't really know about this, but is that like an evidence-based found that self-reported is the best form of data? And if so, in like what venue is that best?
Yeah. So I actually have, I can give you a bit of background on that. Excuse me, happy to share that with you. I believe it's the Institute of Medicine looked at different ways that people share data, and self-reported is best practice, and just because by virtue of the fact that the person themselves is relaying their race, ethnicity to a provider. And there's a toolkit. It's a HRET toolkit. I can't recall the specific, I don't want to give you the wrong title, but the HRET toolkit has best practices for how to ask for this information in a way that folks will feel more comfortable to report it. So I'm happy to share that with Covered California.
Sure. I guess the other question related to that was the venue. Is the doctor's office? Is that like telephonically with the health plan? Is that in the application for coverage?
So the toolkit looks at all different aspects of that. So, when a person shows up to a hospital and they're talking to like the frontline staff or, it's a call center, there's different ways to ask the questions. They pretty much are the same across, regardless of who's asking the question. But some examples are, just explaining to individuals that that you're asking for this information, that it's confidential, and it's optional, but that it will help to improve healthcare for everyone. So, when you put it into this context of, the reason we're collecting this is because we want to improve healthcare experiences, that people are much more likely to, they'll feel more comfortable to share that information.
Yeah, there's a question. QHPs could employ screening tools for social determinants of health, and some do already. However, what would be built in to assure the availability of community resources? For example, what would be the expectations of community services to accept referrals, as well as government funding sources for these services, which for the most part have challenges with sustainable revenue streams?
Well,
those are great. I would just say briefly that those are some of the questions we have very much on our, this is Taylor with Covered California. Those are some questions we very much have on our mind as we approach it's excellent stage setting, I think, for some of the discussion we'd like to have later in today's discussion. Those are very much some of the things that are on our mind.
Beth with Health Access, just to say that we have coped with the variable capacity of agencies. For example, CPAN a few years ago did a bill on what happens when homeless people are discharged from the hospital. And obviously different communities have different resources in terms of what's available. But the first thing is for the hospital to know what those resources are. And so sometimes even, and I would actually go back even further, 20 or 25 years ago, the law changed to require that hospitals be able to give a referral to a nursing home, a choice of 3 when you're discharged. And that at the time was seen as a big innovation and is now built into the system and is very helpful to families who are being told, hi, your mom's being discharged next hour. You're like, oh, and I'm supposed to put her where? So sometimes even just very basic steps are steps forward. And so while acknowledging that it would be terrific if the nonprofit part of the world further strengthened the community services that are available. That I think always in this work we have to recognize that what's available in Los Angeles will be different than what's available in Eureka. And so we just have to be, it's a fair question to ask, but and an important constraint, but we've worked around it before.
And if I could just add one more thing, you know, in Medi-Cal, there's the Health Homes program, which, you know, is it's one model, but the way that, you know, I think there are models out there that, you know, could be instructive. And part of the way that works is there is a sort of community-based sort of entity that is above all other entities that sort of helps to be that central, it's like the hub and spoke model. So it's sort of like the hub where, you know, a plan can contract with to then sort of begin to make some of those referrals. And oftentimes, and I'd like to put a little plug in for, you know, health centers, for community health centers and FQHCs with the Health Homes program. They, you know, have been the organizations that are contracted at that sort of hub and spoke level because they, you know, are in oftentimes in communities already, have some of those linkages and, you know, can help make some of those, you know, help make some of those referrals as well. So it's going to take, you know, the funding is the question. It's going to take, you know, some potentially different structuring to make it happen. But, you know, I think there are some, you know, there are lots of interesting things happening around alternative payment models where, you know, there could be some potential linkages to help make these types of referrals happen.
All right, one more question and we have to move on.
Jen, you've been unmuted.
Yeah, I just wanted to add on to that many of the same groups that are in our Health Consumer Alliance that handle some of the covered California issues, those local programs often have medical legal partnerships as well, and they're used to doing this kind of, you know, whatever it takes triage modeling. So it would be great if they had medical legal partnerships in all provider settings, but the organizations that back them, they can also handle many of these other social determinant issues, whether it's assistance with housing issues, evictions, or other public benefits or things like that.
Great, thank you. All right, and thank you, Carrie. All right, we're moving on to our roundtable discussion. Taylor will lead us off.
Hear me if I sit here, or should I be closer maybe?
You.
Thank you very much, Carrie. And what we want to prioritize today is a lot of time for discussion. So for those of you who have previewed the slides, you see that we have quite a few, but I will try to move very, very quickly. We, at a high level, have tried to organize our discussion for today kind of around 3 key areas, which Carrie really nicely laid out for us. We wanted to start with just a very high level kind of summary of the requirements currently in the current Attachment 7, which covers 2017 now through 2021. So this includes some of the very specific reducing disparities requirements, as well as some broader requirements around promotion of community health and other population health improvement activities. We also did want to ground our discussion today in some of the findings from HMA and also PwC just one more plug for that 300-page report earlier this summer. There's a lot of fantastic information there. And so this is just a quick summary of HMA's high level, the sort of rolled up recommendations and findings around approaching health equity generally and specifically reducing disparities. Very consistent with what you heard from Carrie as well. And we did want to highlight the importance of the multi-pronged approach and really embedding a health equity strategy in sort of your overall quality improvement and reform activities, which is an approach I think we're very much interested in taking ourselves. So we did want to start with data collection and measurement. I'm going to move very quickly because Carrie did a fantastic job of walking you through some of our current requirements. So we do have both the requirement for health plans to collect self-identification of race and ethnicity and their members with a year-end 2019 requirement to hit 80% of their membership. We have just a quick summary of the sources of information. We do have a very high voluntary response rate on the enrollment application through Covered California, which is helpful for this requirement. And then secondly, we have the requirements specific to the reducing disparities data submission. So these are 14 total measures, a combination of HEDIS and the ARC-PQI measures focused on these 4 disease states based on the extensive evidence for disparities in these areas. And the current requirements in the contract are for submission of aggregated data across all lines of business except for Medicare. I'm going to move very quickly, but please stop me if there are questions. And this is just the full list of the 14 measures that are currently required. So when Carrie referred to the baseline data, these are the measures that have been submitted for 3 or 4 years now. Yeah, Beth.
Beth with Health Access is probably a clinical question, but I had thought heart disease was on that list. Is it just not prevalent enough in your population to be, I mean, all those diabetes, hypertension, asthma, and depression make lots of sense to me, don't get me wrong. I just don't recall, I had thought we had included heart disease.
No, there's heart failure.
Yeah, yeah. I just did as the other one that's a big one where you want to look at, well, actually, we want improvements overall and we want to reduce disparities.
That's true.
Yeah.
And actually, thank you, Beth. Lance Lang, our CMO, is not able to be with us today, is taking vacation, and that would be our phone a friend for our clinical questions.
That's fine. I recall 5, so I wasn't going to.
So where we are now, after several years of baseline data submission, is working with our issuers as they are setting up interventions to start to focus on, and this is, many of our health plans are already engaged in this work outside of their contract requirements, but there is a performance standard in the current contract related to intervening in one of these, identifying one of the disparities identified in their data and actually implementing interventions and ultimately performance standard tied to the outcomes of that intervention.
So remind me who picks the
issuers propose a selected subpopulation and disparity with an intervention, and then it's subject to Covered California approval. So it's kind of a collaborative process.
I appreciate the collaborative approach. I just, you know, if it were me, I would pick the one I would think I would do the best on. So rather than the one where the community, as a group of policymakers and from a clinical perspective, you think that there's the greatest need for improvement. So I know we're moving through this and moving forward with this. So it's not a criticism, it's just an observation and to help as we think about it. Okay.
You know, it's a fair point about on this one, at least for us, those two things are the same thing. the one where you have the most need for improvement
Yeah,
is
the
the
least.
one where you can do the best on, because as you make incremental improvements, it gets harder and harder. So this might be one where letting people pick isn't as problematic, but anyway.
Well,
it's a starting point.
Yeah.
The other key factor is for certain plans, we're going to get into kind of some of the challenges with data, and so there can also be kind of real limitations with.
No, I'm not disputing that. I'm just trying to. Part of this exercise is to look forward from what you're doing now.
Absolutely. So we have enough challenges that it takes 2 slides to run through them. And this is sort of a combination of like what we are learning from our experience with the current contract requirements. So as I think most folks know, we also have, there's both the disparities data that is being submitted directly to Cover California's Plan Management Division. There is also the kind of overarching claims and encounter data submissions going to our Healthcare Evidence Initiative, which is the IBM Watson subcontractor. So one of the things that we're thinking through going forward is kind of the balancing of that reporting and to what experient, those of you familiar with the PwC recommendations around data collection, we've been encouraged to look at IBM Watson and how we might do more of this data analysis in that data. Though, as we're pointing out, there are some limitations in looking at just claims and encounter data. There's really important sources of information at a clinical level that some plans may or may not have, and so we're certainly looking at ways to improve and expand the types of data we're looking at. Because we are looking at this sort of aggregated data, we are fairly limited in our ability to identify Cover California specific disparities. We don't currently receive information on a regional basis, so we're unable to look at kind of regional differences, which are certainly relevant. But on the flip side, because we are slicing data by race and ethnicity subpopulations for some plans, that can lead very quickly to very small denominators when you are subsetting for a particular disease state and then further subsetting for race and ethnicity. So that is going to be kind of a constant tension that we're looking to balance. And so related to that, the current work is really limited to sort of observed differences. We're often unable to reach statistical significance for certain disparities based on those small denominators challenges. And so as a related factor, we are looking at, we want to be mindful of what are realistic interventions for our plans. So we engage with them pretty directly around what the data is that they are working with, what models they have available, their sort of respective experience with disparities reduction work. We have some plans that have pretty extensive experience and successful histories in this area, and some that are a little newer to it. So we don't want to be asking for very large scale interventions that are not necessarily well tested or proven to be effective in similar populations. And then just a note here, we have in order to provide adequate time for implementation of those interventions and wanting them to be successful, we did delay assessment of the performance standard from 2019 to 2020. So there are still requirements in place to be moving forward with interventions, but the outcomes measurement tied to a financial penalty or credit did get delayed to 2020. And this is a kind of a key open question for us moving forward. To Beth's point, what are the requirements, and what are certainly, if the goal is improvement in disparities in terms of outcomes, how do we allow for testing, experimentation, which is not always going to be successful, and in many cases where we have plans operating in lots of different communities and geographies, interventions that work in one area are not necessarily going to make sense to scale or apply to other interventions, to other communities or geographies. And so how do we account for both accountability, but also an environment of experimentation and learning from what works? that's a key question for us. And then, of course, as you've heard consistently, we are certainly interested in expanding the types of data that we are looking at and the types of disparities that we are identifying and intervening in. And I am almost done talking. This is just a quick recap so that it's handy as a reference for today's discussion of the recommendations from both HMA and PwC. Again, PwC's recommendations are very specifically focused on measurement and sort of appropriate benchmarks for us to consider. And then HMA's were more generally, what are some best practices in health equity? And so these are the ones related to data collection and measurement for us to consider. And I think from there, we would like to open it up. We have a couple of suggested discussion questions. We'd love to hear from the group here. We've got folks here and on the phone with really extensive backgrounds in this work. We've got representatives from the plans and from other entities, and so we really want to make sure we're hearing from everyone. We would suggest kind of tackling some of these questions, but if there are other points of view or topics that we should be thinking through, we would want to hear that as well. So we would be curious to hear how various organizations define health equity or disparities, current practices in measurement and collection of this data, and suggestions to improve our measures and the way that we are collecting data. So I think with that, we'll turn it over to the group. And for those on the webinar, please feel free to raise your hand, and Elena's keeping an eye out.
All right. Hi, this is Nancy from HealthNet. I know at HealthNet currently our sort of lens for health equity is using the variables we're using right now around race, ethnicity, and language, right, as a proxy. And so, you know, it's important for us to really integrate our data analysis in all of our quality improvement work, but also we're expanding that to, you know, disease management, case management, not just in looking at our population, but who's utilizing the program, right, engaging the program. There are disparities in access or program engagement, as well as outcomes. But I did want to touch on that comment about, you know, we as health plans, we share disparities data on all 14 of the measures, right? So, and we do see multiple disparities. So how do you pick that one that we, you know, we have accountability, eventually performance guarantees for? So maybe a possibility is for us to tackle multiple interventions, but be you know, accountable for that one. That may help kind of look at various approaches to addressing the diverse sort of level of disparities and approaches that has to be tackled. So you know, just to throw it out there. And also, you know, there's been discussions about aligning with Medi-Cal requirements. So, as you know, the community advisory committees that Kiri talked about, as well as the group needs assessment, which is the community needs assessment. So integrate some of the recommendations, for example, from Care Oregon's recommendations, but also, for example, DHCS is requiring a health equity PIP, right, performance improvement plan. So there's an opportunity to align, and usually, you know, typically we do see disparities with our Medi-Cal and Covered California. There's some alignment there, right, similarities. And so some alignments there for plans to cover both lines of business, to focus on maybe disparities that can impact larger than just the Covered California population.
Great, thank you.
Sure.
Let me ask about that for the Medi-Cal alignment. I think it makes a lot of sense to us. Is there some reason anyone could think of why we wouldn't want to align with what Medi-Cal is doing in this area?
Yeah, two things that come to, Beth, again, that come to my mind that I just, it's not don't do it, it's just be conscious of it. Not all of your plans are heavily in the Medi-Cal space. That's just something to keep in mind. Secondly, your population is rather different than the Medi-Cal population. Your population, 95% of them are ages 18 to 64, where the Medi-Cal population has a very significant population of kids and also a significant population of seniors and people with sufficiently severe disabilities that they're on Medi-Cal or Medicare rather than on commercial coverage. And I'm not going to, there are certainly people in commercial coverage who have significant disabilities, but almost all of them have wraparound Medi-Cal coverage to cover things like wheelchairs that aren't normally covered in commercial coverage. So I just think as you do it, you need to be conscious of the difference in population. And I would also, the third point I'd make, and it's, I mean, fundamentally Covered California aligns with the commercial population. Part of the convenience of Medi-Cal is it's another state agency, so you can communicate easily. And I'm not saying don't do it. I'm just saying, again, Covered California is in, you know, and I think the networks reflect this as well as everything else is more akin to the commercial population. The difficulty is that this is this kind of year-over-year improvement in disparities is best managed through a contract, and that's not how it functions in the commercial function. So just as it's not don't do it, it's just be mindful of these things as you think about it, is what I would suggest.
I agree with that. I think that things that would rise to the top for the Covered California population are not necessarily the same as would rise to the top for Medicaid. It's not that it wouldn't do good in the world, but
yeah, you spend a lot of time on kids and adolescents, which
right.
makes a lot of sense in the Medicaid population.
So as an example, you know, pediatric asthma makes all the sense in the world in Medi-Cal. It's not that it doesn't make sense in Covered California, but is it the highest bang for the buck as opposed to diabetes, as opposed to hypertension? That's less clear.
James, was your question specific to a certain set of measures, or?
No, I just wanted to get a sense of, you know, alignment with Medi-Cal. It seems like an easy approach, but I want to see what the pitfalls are for us to do that, and before we go down that road.
And I can share, we do see alignment because our Medi-Cal population has significantly changed over the years. It used to be, 70% moms and kids, and
right.
We're seeing adults and, sort of the
absolutely
really overlapping with Covered California and moving back and forth, right? Depending on eligibility.
Yeah, I'm not saying it doesn't make any sense. I'm just saying you want to be thoughtful about how you do it.
I have a statement here. Disparity reporting under Attachment 7 has been very challenging to our plan because we are required to submit data for not only Covered California, but our other lines of business. Covered California represents less than 5% of our membership, so the figures we submit are not remotely representative of Covered California members. As such, we can't move the rates by focusing on Covered California members. Finally, Attachment 7 is not in line with the requirements for DHCS, DMHC, and other regulators, which makes reporting and intervention very difficult. We ask that the revised requirements be aligned with other regulators and the reporting be focused on Covered California membership.
So let me, Health Access and CPEN co-sponsored AB 929, so we've spent a substantial amount of time on this particular question. I think when we look at disparities, and Carrie is much more eloquent on this than I am, and we look at subpopulations, particularly in the API community, but also other communities, it's helpful to have larger populations to draw on for exactly the reasons Taylor identified, that we get into small subsets. And I appreciate the challenges plans face and the providers face, but we are trying to use the work. Covered California is now as large a purchaser as CalPERS, and, can play a similar role in helping to transform the whole market. And so you need to be thoughtful again about how this is done, and I am very mindful of some of the practical problems, but when we think about populations, API population is so diverse, and in truth, the Latino population is more diverse than we sometimes acknowledge. So I just think that having bigger data sets, aggregating over multiple years, all those sorts of things are just, from a statistical analysis sense, make a lot of sense. So,
and I would just piggyback on that, just to say it's not just about the populations, but it's about the disease progression. So if you're trying to tackle the issue of asthma, and you already know, I think it's like 6 to 10% of the population, it's not a very high percentage, and then you're beginning to, disaggregate data at that level, and then you also want to make regional inferences and think about, regional variation, and you really do need access to, the larger data set. So it is really, I think, a best practice approach. And then we also know that, folks do move. There's quite a bit of churn between, in and out of the exchange between Medi-Cal and Covered California. So, we also are mindful of the fact that people, you need to be able to see how, Covered California is doing, compared with someone in, Medi-Cal or in commercial insurance, and you're not going to be able to do that if you don't have access to that data, because that person does not just belong in one program.
Mm-hmm. And Carrie, just to follow up, this is Taylor again with Covered California. The reason that we would care about something like asthma, where maybe the statewide prevalence rate is only 6 to 10%, is because, as you walked us through earlier, within that population, we see fairly profound disease burden disparities for certain populations. And so that might sound like kind of a small number across the entire population of California, but when we think about the actual lived experiences or impacts to someone who's experiencing a disparity in their access to care for asthma or their number of emergency department visits or hospitalizations, that's why that disease state still matters very much to us.
Right. That
we need to still understand the disparities experienced and those.
And I think Dr. Lang would say, if he was here, that these are ambulatory care sensitive conditions. Okay, like if you have cancer, you have cancer. Like it's important that there be quality treatment, but these are things that are preventable and avoidable costs. Mm-hmm. So not only is it, kind of the morally, potentially right thing to do, but it's also where you want to go if you're really trying to, look at the triple aim and reduce, these complications later down the road. Giving someone the asthma inhaler before, asthma progresses to, another level is going to keep costs down.
But I want to come back to something that Carrie mentioned in her presentation that we kind of skim past, which is some of this is about, and I don't want to call it health literacy because that suggests you're paying attention to your copays or how your deductible is tracking or something, but the ability and she talked about it a lot in the findings of the focus groups, the ability to understand what the asthma management program is and why it matters. So at one point I worked with a group of community clinics that was dealing with uninsured kids with asthma, which is a really hard, and they were still able to dramatically reduce hospitalizations with home visits. But the misunderstandings, inhaled steroids will make the kids sterile, the not understanding how to administer just basic stuff, what it is to try and have a dust-free environment in a rented apartment. All those sorts of things are really hard for people. And so I think in some ways, income is closely correlated with education, but not perfectly. And so I think some of what we're actually reaching to is education. My mother was college educated. She didn't understand that getting my room clean meant getting rid of the rug. I mean, nobody till somebody said, got to do that. And so college educated in an era when most women were not. And so I think it's, I think part of what we're measuring for here is education, and you don't have a direct way to get that because you collect income because of, whether it's here or in Medi-Cal, because of eligibility. We're working on race and ethnicity and language and all that. But I think underlying this is too often we have a healthcare system designed for the people in this room, well-educated professionals, and we fail to, or are not frightened their kid is going to die. Okay, which, whatever education I had goes out my head at that moment. So I think just as we're thinking about this stuff, in some ways that's as much a factor as anything else. Sorry. Thank you.
Okay. Thank you. Well, that's a good transition to our next topic here. And those of you with questions on the webinar, please hold, because shortly here we'll have opportunity for you to ask us questions. We're going to talk about access to care, and we definitely recognize this is a barrier for patients to get the health care that they need. Currently, for Covered California, we require that the QHPs monitor provider networks for unmet cultural and linguistic member needs, and then also make available to members online tools or other methods to communicate provider audit and cost of services. And we also want to have them report the number of % of members who have utilized preventive care, tobacco cessation, obesity management. Here are the HMA and PwC recommendations and how we can improve access to care. I just want to highlight some of these. The HMA definitely wants us to promote the use of non-clinical providers, like health workers, and it's been shown to improve access to care and address social determinants of health as well, reduce health disparities. Also want to highlight patient engagement and activation. Definitely engaging the patient and their families and the care will improve not only health outcomes, but reduce disparities. And then PwC just reiterate that we should track and measure beyond race and ethnicity, looking at regions, geographies, rural versus urban markets. So our question to all of you is, what does access to care mean to your organization? Is that your timing, location, in-person, telehealth, provider type, or culturally congruent care? Carrie mentioned this in her presentation. We hear a lot about cultural competency, but we really need to talk about cultural congruency. And what is that? So cultural competency, right, is the understanding of patient's culture, but cultural competency tends to stay at a provider level. It is the provider in the system, whereas patients, consumers come to the doctor's office or come to different organizations with their own beliefs and their own visions and their own values. And so the meeting of the two, the system and the patient, is where you find the cultural congruency. And so that's really where we should be focusing on. And then again, other questions, how are your organizations addressing patient access, and what can we do to improve at Covered California? Opening it up to the group.
Todd May, HealthNet. Access boils down to right care, right time, right place, right? And you need all the modalities and others that aren't even on the list to allow patients to have the access they need. And they so we're providing as many forms as possible, whether it's MediClinics, urgent care, telehealth, self-help, self-service tools, online, etc. I think a key challenge is having members actually know what their options are and how to access them. That's really the biggest challenge, because we're providing a lot of options and opportunities, but by getting them connected with, make it the right care at the right time and right place.
Who are the questions from online?
Nancy from HealthNet. I just wanted to add to that. In terms of sort of the community perspective, we're also, and I think this is something that really ties into how do we address social determinants of health, social determinants of equity. I saw one of the terms. I think that's really how we should frame it. How do we use community connectors, whether it be community health workers or health navigators that health plans can help support, insert into provider setting, and even directly staff within the health plans? For example, HealthNet has a community member connections program that's an in-home, really community health worker approach, but cold knocked in the home to actually, help coordinate care. But how do we scale up those models? And there are many different types of community connectors, types of models, right? And I think, as we look at intervention strategies, we're going to see a lot of that in terms of how do we connect folks to social services, social determinants of social services. And then I wanted to get back to, Bev, you made a point of that, not necessarily the need to kind of look at capacity of CBOs, but it starts with the members knowing what social services they offer. So, I think as health plans, one of the foundational kind of steps to doing that is ensuring that, we all have a platform, a social service platform referral source, and possibly a closed loop mechanism. So there's back and forth with the providers and social services, and really engage the providers and members to know the services out there. That is the first step, and I don't think we're there yet. And then, of course, look at.
But trying is an important first step.
Trying is the first step, exactly. But to start somewhere, it's a continuum, right? And then, of course, look at community investments and, kind of directly funding CBOs. But really, it starts at, even letting our providers and members know and how to connect all the services in their communities.
Ty Frosser from Blue Shield. One of the just intriguing things on this is culturally congruent care, and I'm going to, what data elements would you show in a provider directory that would then help people do that? And I don't know that, the network side is my area. I'm certainly interested in it, and one of the possible ideas is, if that's defined somewhere, using Symphony, the statewide provider directory through IHA, which I think in its end state, providers would update directly through Symphony as ways to capture that data and store it and then share it out. But I'm definitely interested to get the groups thinking, or where things would be heading as to what data elements could be used that could communicate that out, and then using something like Symphony as a repository to publicize it.
So, working with the LGBTQ network, we've looked at this, LGBTQ issues. The challenge then becomes there's no certification, right? And so self-report has its limitations, shall I say. And also for some kinds of care, let me try and think of something. For some kinds of care, really want providers not to discriminate. You just want them to provide the care. And I think it depends on what you're talking about. If you're talking about an oncologist, they should, cancer care should be cancer care regardless of who you are. On the other hand, if you're talking about primary care, I keep coming back to the need for domestic violence victims to have API sensitive, meaning they serve rice, not potato. I mean, it's just sort of basic. It's like what makes you feel comfortable when you're in a terrible situation. And so I'm sorry, those are homely examples and probably not the most elegant ones, but it's, it's a good goal to have. I think it requires all of us to spend more time thinking it through.
How do you measure it?
Yeah.
So that's sort of could use the group's thinking on.
Yeah.
Yeah, I know that for me, when I think about culture congruent care, events directives are something that I think about a lot, especially end of life care and events directives. And I think that as an organization, hospital organization, you can create a standardized events directive, but in order to make that more culturally competent or culture congruent, like that should be adaptive, right, to different subpopulations that you have coming to you. And then within that, even especially the Hmong community, like speaking about death is like a taboo thing. And so for the provider to understand the different dynamics that is involved in a discussion end of life, I think that is where we get into the culturally congruent.
Yeah, and that's interesting because I could also speak to some of the message earlier about wrapping this with community-based organizations.
Exactly.
Sort of that broader team perspective, which may not necessarily be solely a provider and his or her office or practice, but in partnership with other organizations on that to get that. But again, it goes back to are there ways we could measure, tangible progress in that?
Right.
Well, and then just one other thing too, I mean, I think we have, California, we have requirements or, training programs around, cultural competence that providers can participate in. But I think this issue of like cultural humility or implicit bias or some of the other, terms that people are talking about are also really important because, we've also found, I mean, even seeing someone, who is from your same, ethnic, racial group, we've also heard that doesn't always necessarily, lead to better care. And so, I mean, while we certainly want, more congruence there too, that I think, thinking about these types of trainings and, potential and encouraging, requiring, incentivizing, and you can also note that in your, directories as well. So sort of, I think there's a way to think about how to incorporate something like that, and then just signal that, this provider has been trained and, is thinking about these issues.
I have a question online.
Robin, you have been unmuted.
Yeah, this is a great topic. Some of the things that I think we've been able to do is really look at what does culturally congruent care look like. And I know based in clusters of ethnicities in our communities, we've stood up some culturally congruent care clinics so that the providers within those clinics speak the language as well as understand the culture of the individuals that go there. I think too is just knowing more about your population. If you have a large population that are predominantly hourly workers, expanding hours so that they can get the appropriate care at the appropriate place at the right time and not when they're trying to make a dollar for their family. I like that you included optional modalities such as telehealth because that's been expanding and people are really taking advantage of that, and it really eases the way for our members. Another thing we've done in measurement is we do have a lot of regulatory requirements around geo access and then timing of when that first appointment has to be and access to specialty care and things like that. But we kind of balance that with our members' response to their perceptions of the timeliness of care and their ability to have access. And I think really using that as a barometer is a better measure than did we meet the regulation. So it's a great topic, though. Thank you.
Thank you. Robin, what organization are you from? Sorry.
Kaiser Permanente, Northern California.
Thank you. All right. We have one more.
Mary, you've been unmuted.
Hi, this is Mary Jamona from Molina Healthcare. And most of the work that I do is with Medi-Cal patients because I'm in director for our pediatric and CCS support team. And one of the key pieces of support that our team uses is case management, complex case management for our members, many of them because they have CCS, or if they're not on CCS, we have a special program for peds asthma and so forth. And in listening to the discussion today, even though supposedly people on covered California might not have as much disabling condition, it makes me think that in addition to navigation and having community health workers, it may be something for covered California to look at, to think about a case management component for members, especially members who don't have access to the culturally competent or culturally congruent care that's needed, because the case manager might be able to be the facilitator or bridge for that, just like a community health worker could be. But if the member has more complex care needs, that's when a case manager, who might be a nurse or a social worker, can come and work with the provider or work with the member, do health education and so forth. So that could be another component that you might want to build in for those members that have more complexity of care, they aren't on Medi-Cal, but they still need that intensive support that might only be available through someone in a case management program.
This is Beth with Health Access. Just to say that CCS provides that support for children with disabilities, and from my family's experience, the only thing wrong with CCS is it cuts off at age 22, as opposed to age whenever. And so I would heartily echo that for people with complex needs, whether it's persons, and there will be persons with disabilities in your population, or people facing, I guess I want to call it more complicated cancer. You know, stuff like breast cancer and prostate cancer is kind of routine now. Hip replacement's kind of routine, but there are people, and I know it's another part, but and that also that needs to be sensitive to the needs of the family and the family situation, which, you know, ideally case management is.
Thank you. In the interest of time, I know we only have 11 minutes left for this session, so we do want to introduce this last section of our talk today.
And I'm kind of wondering if the group feels like we've touched on a number of these things. Our key messages that we just wanted to communicate is that Covered California is considering a distinction between sort of what we think of as the upstream, the traditional social determinants of health versus what we are referring to as patient-centered social needs. So on an individual patient level, we did want to kind of frame our discussion. So this is a quick reminder of kind of what the fairly limited existing requirements are in this area. This is a new area for us. We are certainly interested in continuing the conversation beyond today. I know we've got a number of folks who would also like to contribute comments on our discussion so far today. We did get feedback from HMA and PwC in this area. I think something we would like to recommend is additional discussion opportunity on this topic. We are getting recommendations that sort of run the gamut from, you know, requiring that health plans implement comprehensive social needs screenings and having referral processes in place, all the way up to sort of engagement in true upstream determinants. And so we certainly want to have more than 9 minutes of discussion on that topic. And again, we know we have a number of health plans currently working with us, as well as other organizations that are deeply engaged and experienced in this work. So we do want some future opportunity to hear from learned experiences and some developing best practices there. So we do have a couple of questions. If there's anything social determinants related that we haven't covered, I know it's come up in a number of our other conversations earlier today. We'll pause here, and I think we have a number of folks with comments.
And I do want to emphasize to those of you on the webinar, if you have a question and you've been waiting, go ahead and type into the comment box, because those stay even if the webinar is over. So we may be able to get back to your question at a later time.
Mary June, you've been unmuted.
Hi, this is MJ with SEIU California now. I actually had comments on the previous slides regarding to access and locations of not only healthcare, but also the social services necessary in order to really address some of the social determinants of health that we see in many people. I would be remiss if I didn't say that, you know, SEIU represents both the healthcare and also the social services providers that have the proper training as well as the experience and connections in the community to be able to help build on our existing healthcare delivery system. And also we are working on strengthening and expanding those types of delivery systems while ensuring workers throughout both public and private health systems are organized, and also services are accessible to the patients, which is what we care deeply about. And so I just wanted to say that out loud, then when we're talking about access and how we can engage community-based organizations and also community health workers, SEIU is also very interested in how we can get those partnerships, because at the end of the day, we do want to not only help our patients, but also create a health system that is equitable both on the patient side, but also on the provider side.
Thank you, MJ.
Leslie, you've been unmuted.
Hi, this is Leslie Goodyear-Moya from HealthNet, and I actually wanted to go back quite a bit back in the presentation, but I'll just make my comment quick. In the mapping and measurement piece, there was an HMA recommendation to use the Medicare mapping tool, and I think that while that is a good tool, I think there's a big challenge with using that tool, which is that the tool only provides data at the county level. And what we found in our work when we do geographic analysis is that we have to get a lot more granular in order to have really specific and focused interventions. And in terms of being able to calculate kind of returns on investment or even looking at, change over time, the county level doesn't do it for us, especially in more urban counties. And tying into the social determinants of health section that you're on, in order to look at the population-based SDOH data, we have to be very mindful about what geographies we're using when we do outcome analysis and compare it apples to apples with population-based data. So I guess that's my comment, is that we need to kind of think beyond, or I guess within counties. Thank you.
That's really helpful feedback. Thank you very much.
Jen, you've been unmuted.
Yeah, just in terms of the social determinants of health, just one interesting parallel that I wanted to draw with what's going on in the housing world. I mean, I'm sure it's not news to anybody that we're facing somewhat of an unprecedented housing crisis. And with my colleagues that work on housing, their solutions that they talk to about the crisis are very similar to, when we're trying to push prevention in healthcare, they're trying to push prevention in not losing your home or your apartment. So that may be one kind of test area where we can look. I know I went to my doctor recently and was screened for domestic violence and other things, but screening for housing insecurity, because a lot of what becomes homelessness later doesn't present itself as that early on. And so, if we're trying to think of some good social determinants, that's one of the ones that has the most detrimental effect on your health. And people are often in various states before they end up on the streets, where an intervention could be helpful. So I just wanted to highlight that for a potential for a conversation separately on that it sounds like we're going to need to have.
Can I just mention one other thing too, as we're talking about social determinants, there's and we'll share this, but I think there's been some really good recent research looking at Medi-Cal managed care plans and their use and their engagement on the social determinants of health. I think it was JSI just published a report, and I think that might be a good thing to share with folks. There are a lot of plans that are addressing this and that are kind of looking at various needs, and housing. I think it's like housing, nutrition assistance. Those tend to be like the top issues that are coming up, but there are different ways and different levels of engagement by plans that could be instructive in this conversation. So,
thank you. Any other questions? Okay. I mean, there's a lot more that we can talk about with health equity. And so I do want to reemphasize that health equity is not just limited to today's discussion. We'll be talking about it, reducing disparities in every single work group meeting that we have coming up. And so we're going to take everything that we talked about today and sort of digest it and then revisit it at future sessions. We have some discussion questions here, and we're not going to have time to get to. So maybe those of you here and online can get back to us via email. Especially number 3 here, because reducing health disparities crosses multiple domains. In the QHP model contract, would you recommend that health equity be embedded into each of these domains, or would you recommend that health equity be its own unique section? And so we can definitely talk about this at a future meeting as well. In terms of next steps, we do have a meeting coming up in November and December. November, we focus on mental health and substance use disorder. We have some great speakers lined up for that. And the December 5th, will be primary care. For 2020, the schedule is not up yet, but I'll get that to you soon, shortly. All right, before we go here, I just want to thank you all again for your participation. If there are any last minute questions or comments, I gladly take it right now. Otherwise, you can always email me or Taylor.
Hold on, before we go any further.
Oh, sorry.
Don't email Taylor.
Yeah.
Oh, that's right. Sorry.
You can email me for 1 more week.
I forgot.
And then you won't see my picture on that slide anymore. It'll be Ty after next week. And I look forward
Starting
to.
in a couple of weeks, we email the Taylor family.
And when do we hope that you will be rejoining us?
February. I look forward to being back part-time in February. I'm really sad to miss some of the topics over the winter, but I look forward to being back in February.
Listen.
Yeah. But thank you. Ty is doing a fantastic job coordinating this group. You guys are in great hands.
All right. Thank you all. Thank you for joining us.
Thank you.
I'm sure you get pretty bored, as I recall.
Right.